Yeah.
Yes.
Very good evening to everyone. I welcome all the members of KSCASI to this case presentation on Zoom platform. As you all know that KSCASI does a lot of these programs online, offline, both the things for postgraduates as well as for the consultants. Today we have Dr. Yasaswini, second year postgraduate from B.M.PATIL Medical College, who will be presenting a case, neck swelling, case of neck swelling. And this session will be moderated by Dr. M.B. Patil, Vice Principal in B.M.PATIL Medical College. He is a professor in Department of Surgery and Vice Principal Clinicals in B.M.PATIL Medical College. And I request all the participants, if you have any queries, please put your questions in the chat box. So whenever it is time permits, we'll try to answer or we'll put across the faculty. I request Dr. M.B. Patil to start the session.
Good evening, everyone. Thank you, Dr. Chandrashekar, our dynamic secretary of KSCASI. Today we have eminent faculties to discuss about this case. Dr. Rajgopal Shenoy, former head of the Department of KMC Manipal, presently working as Associate Dean Academics. As all of you are aware, very popular teacher across Karnataka and across whole of India. Thank you, sir, for joining us. And our next faculty is Dr. Shrishail Metgud. He is presently working as professor and head, KL University, SHRI Jawaharlal Nehru Medical College, Belgaum, Karnataka. And I also welcome our own professor, dynamic professor and head of medical education unit, very passionate teacher from our own college, Dr. Vijaya Patil. I request our second year junior resident from our college, Dr. Yasaswini, to please go ahead and you can proceed with your presentation. I also request the faculty to complete our presentation one by one, and you can always go back and ask questions as and when required. Kindly requesting to avoid overlapping of questions. In case Yasaswini is not able to answer any question, the faculty can answer that and proceed on to the next level of examination or presentation. Thank you. Kindly go ahead with your presentation, Dr. Yasaswini.
Yes. Good evening, professors. I want to sincerely thank Karnataka State Chapter Association for giving me this platform to present this case. I would also like to thank my institute, Medical College, and
Let it be a little louder, madam.
Vijaya ma'am, and even M.B. Patil sir for helping me with this presentation.
There is a small echo. Yasaswini, one
yes, sir.
more system is, I think, on in your room. So maybe that is causing echo.
Ma'am's.
Yeah. So if
yes,
we
sir.
have two systems in same room, it will cause echo.
Yes.
Let
yes,
madam keep it in muting. Let madam keep in muting.
Yes.
No, to help her, I came here, sir. So I'll go that room.
Okay.
Yeah.
Yes, Yasaswini, speak little more loud. Okay.
Yes, sir. Yes.
Yeah, now it is better. Now it is better. Okay.
Yes, sir. Yes.
So, yes, you can probably, I think, madam knows the case. So,
yes, sir. Yes, sir.
You can slowly start presenting. Be bold. Be bold. Absolutely nothing to worry, or nothing to worry, or nothing to hurry.
Yes.
You understand, no? So it is
yes,
a good,
yes,
good gesture from your side to present. We find in PMEs, not many people come forward to present. So we appreciate your, that gesture to come. So let us start the presentation. Yes.
yes sir. So I will be presenting a case of neck swelling. To start, patient details. Patient is a 65-year-old male patient. His occupation is and he's from Hitnali, Bijapur district. He comes with chief complaints of swelling in front of the neck since the last 5 years and hoarseness of voice since the last 4 months. Patient was apparently all right 5 years back, after which he noticed painless swelling in front of the neck. It was insidious onset and it was initially of size 3 into 2 centimeters, which later progressed to a size of 15 into 8 centimeters. He came with a history of rapid increase in the size in the last 6 months, for which he consulted us. He also complains of hoarseness of voice since the last 4 months, which is persistent and progressive in nature. There was no history of pain over the swelling. There was no history of any dyspnea, dysphagia, or stridor. There was no history of chest pain, palpitation, sweating, breathlessness, insomnia, weight loss, diarrhea, or heat intolerance. There was also no history of weight gain, cold intolerance, constipation, or lethargy. There was no history of any other neck swellings, and there was no history of any bony pain, cough, hemoptysis, or any other swellings in the body. Coming to past history, the patient gave no history of any diabetes or hypertension. There was no history of any medication which was related to the similar complaints. There was no history of radiation to neck in childhood, and there was no history of previous neck surgery or similar complaints. Coming to personal history, patient has a mixed type of diet with sound sleep and good appetite with regular bowel and bladder movements, and he has no illness. Family history, there is no history of no similar history in the family or in the neighborhood, and there is no family history of any familial cancers. Coming to summarize my history, we have a 64-year-old male patient with painless swelling in front of neck since the last 5 years of size 15 into 8 centimeters presently, with history of rapid increase in size in the last 6 months, and it was associated with persistent and progressive hoarseness of voice since the last 4 months with no signs of hyper or hypothyroidism.
Okay, Tejaswini, you can stop now. You can go back to the first slide. First slide first. Second, next. Okay, faculty can share their thoughts. Faculty, sir. Rajgopal sir and Shrishail sir.
Yes, sir.
But good, sir. Can you start, sir? I think, yes.
You'll have to tell us the history of progress that happened in the last 5 years.
In the
Progress
last
of the swelling in the last 5 years. Yeah. So- Can
Yes,
you throw
Yes,
more light on what were the events that happened in the last 5 years?
So in the last 5 years, basically, he came with a swelling. Initially, it was around 3 into 2 centimeters. Sir. Gradually, it progressed to around 15 into 8 centimeters in the last 5 years. Sir. But in the last 6 months, it has had a rapid increase of size in the swelling. That means in the last 6 months, around it was 5 into 5 centimeters. Around after that, it started increasing rapidly to 15 into 8 centimeters in the last 6 months.
Okay. So in the last 6 months, if it has rapidly increased, were there any other associated symptoms that we need to find out?
Yes, sir. In this case, he also complained of hoarseness of voice in the last 4 months. So
That you have mentioned. Anything else other than that?
Anything else? We can ask about whether he has any complaints of breathlessness or difficulty in breathing when he lies down, sir. Or he could have any difficulty in swallowing. Or if there are any other swellings that developed in the time period of these last 5 months, sir. If there are any other neck swellings that developed, or if he has any noisy breathing, like when he breathes, is there a noise that is coming?
Would you like to be specific about pain?
Yes, sir. Pain also. Yes, sir. Pain also. If a painless swelling would turn into a sudden turn into a painful swelling, then that could either indicate a hemorrhage in a cyst, or it could indicate malignant transformation of the swelling, which involves if it is infiltrating into the nerves, then that could become painful, or it could also indicate that there is inflammation in the swelling. These are some of the reasons as to why swelling could become painful. One initially painless swelling could become painful.
Sir, Rajgopal sir.
Yeah, Yasaswini, that's fine.
Yes, sir.
As we know that most of us know that anyone comes in front of the swelling, would like to consider most common problem is most probably is
Thyroid.
thyroid. I think the postcard is not, but that exact like telling 5 years back 2 centimeter, now it is 5 centimeter, then it is 15. I think better to use the word approximately. Approximately. I know that examiners don't expect you to tell lemon and all this orange and other things, but so
Yes, sir.
always try to use the word approximately. It was small in size like that, and now
Yes,
gradually increase. You have to highlight any time the difference between what is sudden increase and what is rapid increase.
Yes, sir. So sudden increase would be in a matter of a few days, sir. This is in the period of 6 months, sir. So that is why I classified it as rapid
I
increase.
just want to ask you, when patients, in fact,
sir.
often such a big swelling, suddenly some event happens for which they go to the hospital. What is it like?
Yes, sir. So in case of if there is any trauma or anything, that could be a sudden hemorrhage into the system.
Just hold on, just hold on. How common is to get somebody hitting your neck? It's not common, no. So what is more common event that happens in a goiters? Sudden hemorrhage.
Hemorrhage, yes, sir.
But that is what brings the sudden enlargement. Okay.
Yes.
Now, if I ask you one question, when the goiter is enlarging and sudden hemorrhage happens, what is
Yes,
the complaint for which they are come to hospital other than the enlargement? Dr. Metgud give you a clue for that.
So it could be multinodular goiter with a dominant nodule.
Don't give multinodular. Say nodule compressing on
So,
nodule compressing on
trachea. If it is compressing on the trachea, he will come immediately.
Yeah, simple. If there's a nodule compressing on the trachea, and imagine if there's a hemorrhage, they will come very early. Correct?
Yes. Yes, sir.
Now, so for that, one more question is commonly asked. What is the common site of a nodule in a thyroid gland?
So it could be in the lateral lobes of the thyroid, or it could be.
Right. It can be anywhere. It can be lateral lobe,
Yes,
above, below, but
most common site is the lateral lobe of the thyroid, and it's the most.
It's the isthmolobar junction. That is why they come with the sudden compression, causing difficulty breathing. So basically, you have a patient who has got 5. Sorry, sir. Hello. Yes. The second important thing would like to, can you just change the slide, please?
Yes.
Yeah. So we have written about all that thing, which I think we have clarified. I just want to ask you a few questions because which are commonly asked questions. What is hoarseness of the voice?
So hoarseness of voice is basically a change in his normal
like what? Change
roughness, sir. It becomes a little bit more timbre is increased. Sir.
Don't say roughness. A little bit of low pitch or a husky, or sometimes that tiredness. All that will come under hoarseness of the voice. So in relation to this swelling, what do you think the probable cause for the hoarseness?
So in relation to this swelling, the probable cause could be malignant invasion of the.
No. Don't say malignancy and all. What you have to tell is probably
invasion.
Not invasion. You can only say that it could be related to infiltration of recurrent laryngeal nerve. Okay, that is one thing. Now, what do you mean by stridor?
So stridor is a low whistling sound, sir, which on deep inhalation you will have, there will be a low whistling sound.
Whistling stridor. Stridor indicates basically what? What patients you have seen having stridor?
Tracheal compression with
upper airway obstruction.
Upper, yes, sir.
It can also happen in carcinoma when you can get this thyroid. Yes.
Any vocal cord malignancy can also cause.
Okay, advanced anaplastic variety infiltrating even the trachea, you can get a upper airway obstruction. So what do you mean? Because these are some of the common questions. You know, what do you mean by dyspnea then?
Dyspnea is,
yes.
so basically,
Yes.
in
Correct.
case of a retrosternal thyroid, when he sleeps, that the thyroid will press on his trachea and it will cause dyspnea, the difficulty in breathing.
Correct. So when you have a difficulty in breathing, you have few things to be considered. Like for example, COPD, cardiac failure, retrosternal. When you have a stridor, you have to suspect a little upper airway. And you know that when you have a asthma-like thing, what you said that you know that some kind of a sound during the expiration. So you have to have a clarity on this tip. So your patient has got a basically a neck swelling, and he has got a recent hoarseness since 4 months. Right? And you have written here, hoarseness is persistent, progressive, or what is it like?
So basically, what I meant to say is, in the last 4 months, there has not been a time period where his hoarseness has disappeared. Like it has been continuously present all throughout the 4 months. And progressive.
Yes. And when you say persistent or progressive, I know that what you meant, we refer to say ulcer is progressing in size or swelling is progressing. Here you can only say is worsening of the voice related to his occupation, related to his, suppose he's a teacher or a singer or somebody. This is how we analyze the case. Yes, Dr. Patil.
What do you mean by progressive?
Progressive, yeah, I mean that, so initially his voice was like amongst in the duration of 4 months. By the end of 4 months, it became even more low pitch, even more worse than before.
Okay, fine. You can go. You can proceed, madam. Next slide. You already answered about the pain, the causes for pain in the swellings, and the second one, you ruled out chest pain. Why chest pain, madam, in these patients?
So chest pain would be, it is sometimes seen
palpitation
in secondary.
Can be explained, sweating, breathlessness, insomnia and all can be explained, but why chest pain? Why these patients should have chest pain?
So in cases of secondary thyrotoxicosis, if there is a cardiac failure, they can complain of chest pain. And palpitation also in secondary thyrotoxicosis, we can say. Sweating.
Okay, so unlikely they present with chest pain, madam. But as you told, palpitation and all, they are the manifestations of secondary thyrotoxicosis as well in the primary thyrotoxicosis. What do you mean by no history of other neck swellings? Why you want to ask this history?
I wanted to rule out if there was any other swellings in the neck which could be indicating cervical lymphedema. It can indicate metastasis to the lymph nodes.
So yes, basically you have a swelling in front of the neck with the 5 years duration, correct?
Yes, sir. Yes, sir.
So, and you have a patient who has got a hoarseness of voice. Yes, so what are the problems which you think and probably at this stage because of this long-standing 5 years duration?
Yes, sir. In long-standing neck swelling, if there is also in this case, there was also a rapid increase in the size in the last 6 months. So it could indicate malignant transformation. So that is why I wanted to rule out any lymphatic metastasis. It could be papillary thyroid carcinoma, but in a long-standing.
You just have to probably say that I would like to consider malignant transformation. That is fine.
Yes, sir.
It is let the examiners ask you, like what
Yes.
do you want, so that it's
Sure.
better that you play your safe, because you can get both.
Yes, sir.
The common question which is asked is typical multinodular goiter changes into what malignancy? That's what if you have in mind.
Follicular carcinoma.
Sorry.
Follicular carcinoma.
So then the question that comes is, what are the common metastasis you get from follicular carcinoma?
So follicular carcinoma usually spreads through blood, sir. So it will common.
So that's what I'm trying to ask you. Since you answered about the neck swelling, so that's the answer for that. You can also get, that's a different issue. But
Yes.
you don't know what you are dealing with. You don't know. It can turn out to be something else. It can turn out to be a lymphoma also. We have no idea about it. So you have to keep that all these things in mind. Just say malignant transformation. That is the better one. Okay. Yes. Now you have written this weight gain, constipation, all that thing. So
Yes,
what
sir.
does it indicate you of?
So I wanted to rule out whether the patient is hypothyroid, sir. Hypothyroid.
So anyway, that is the protocol of the whatever the neck swelling, you know, when you get in front of the neck. I have only one important question to you. Forget about the diagnosis which you have in mind. Any patient who is having a swelling in the neck, in the thyroid region, I give a clue to you. One side. And he has got hoarseness, like what you have written there, 5 years duration.
Yes.
Other than the thyroid, can you suspect anything else?
Yes, sir. Swelling in the swelling in the neck or in the front of the.
Like I said, one lobe, like
Okay.
left side.
So
Yes.
if it is on one side of the neck, it could be secondaries in the neck with invasion of the nerves, sir, or compression of the nerves, and it could also be laryngeal carcinoma.
Just hold on, just hold on. Yes, laryngeal carcinoma will have a stridor. Remember, your patient has got 5-year duration. 5 years. 5 years. So I have given a clue to you. One side, one lobe-like thing. So, can you think of when you that amounts to ask one question to you: what are the causes of hoarseness of the voice other than the thyroid swelling, compressing, or infiltrating the recurrent laryngeal nerve?
So, in case of any other malignancies like laryngeal carcinoma, esophageal carcinoma, or any mass in the neck which is compressing on the recurrent laryngeal nerve, it could.
Look, can you get any mass arising from the recurrent laryngeal nerve?
Yes. Any neuromas can also cause.
The areas where you get a neural hemoma is this.
Yes.
Okay. So that is what the answer I wanted, because your patient has got 5-year duration. Okay, that's all. Yes, madam. I think we can go ahead.
You asked this history of bone pain, cough, hemoptysis. What did you have in mind?
So I wanted to rule out any metastatic history, sir. If the thyroid swelling is progressive, I wanted to rule out metastatic history.
Okay. Next slide.
What medication you meant?
So medication related to the similar complaints like any hyperthyroid drugs, carbimazole, propylthyrouracil, or thiazidines. That's or any other medications also you might be taking, like amiodarone also sometimes.
Goitrogenic drugs or drugs being taken for hyperthyroidism or hypothyroidism. That's what you meant.
Yes, sir. Yes, sir.
Okay. Then why do you think radiation history is important in these patients? And
So,
that what type of radiation?
So basically, any radiation, gamma rays in the childhood, sir, if he has undergone any kind of radiation to the neck, external beam radiation, it is known etiology for a papillary thyroid carcinoma. So that is why I wanted to rule out radiation to the neck in childhood, sir. Less than 5 years of age, usually. It is an etiology for papillary thyroid carcinoma.
Yasaswini, in which condition they give radiation to childhood in radiation to neck in childhood. Can you name any condition?
Yes, ma'am. Initially, in the earlier days, they would give radiation to the neck in the childhood in cases of any angiosarcomas, or it could be swellings in the.
Remember mantle field. What is mantle field? Where
yes,
it is
lymphomas also, ma'am. Even in lymphomas, they give Hodgkin's lymphoma.
Angiosarcomas are very, very rare. Basically, in
Yes.
lymphomas, sometimes say earlier days, any thymic swellings. Okay.
Yes, sir.
So for these reasons, there used to be irradiation for these patients. What do you mean by no history of previous surgery in the neck for similar complaints?
I wanted to rule out whether he had any recurrent thyroid disease, sir. If he's already undergone any thyroid surgery and now he's come back with another swelling in the same any recurrence or any residual disease.
Okay. Yes, Shrishail sir, can have any questions if you have about the past history. Otherwise, we'll go to the next slide.
We'll go to the next slide, sir.
Yeah, next slide, madam.
Yeah.
What is the importance of family history, madam?
So family history in a case of neck swelling, sir, basically if it was a endemic goiter, all the family members will be affected, neighborhood will also be affected. If in case of dysharmonogenesis because of enzyme deficiencies, there could be multiple family members who are affected. Even in cases of primary thyrotoxic also there could be multiple family members affected. Sometimes papillary thyroid carcinoma will come with gene defects like a red oncogene defect or PTC, which runs in the family. Hashimoto's disease also is an autosomal recessive condition. Which
Any other familial condition? Men 2A, 2B?
Men 2, yes, sir. Men 2A, 2B also in case of medullary thyroid carcinoma, even that runs in the family. So men 2A, we will see papillary thyroid carcinoma, medullary thyroid carcinoma, parathyroid hyperplasia, and pheochromocytoma. And men 2B, we will see including pheochromocytoma, medullary thyroid carcinoma, and parathyroid hyperplasia. We will also see marfanoid habitus. We will also see multiple neuromas in the mucocutaneous junctions like the lip, tongue, or the cavity.
Okay, you don't see that in all the patients because they can be familial cancers, as you told. It can be sporadic also. Sporadic
Yes,
can have
sporadic.
the isolated medullary carcinoma.
Yes.
Familial cancers are occurring at what age, Yasaswini?
So, ma'am, usually familial cancers will occur in the younger age groups. If it is sporadic, it will occur in the older age groups. Usually, familial cancer will occur, and especially men 2A, men 2B will be occurring in the younger age group.
You said dysharmonogenesis. Which hormones are affected most of the time?
This peroxidase.
What is Pandred syndrome? Congenital hypothyroidism with deafness.
Congenital deafness.
Okay, I think we'll proceed ahead. Yes, ma'am, you go ahead.
Yeah.
Yes, ma'am, go ahead with your summary.
64-year-old male patient with painless swelling in front of the neck since the last 5 years, of size 15 to 8 centimeters, with history of rapid increase in size in the last 6 months, associated with persistent and worseness of voice since the last 4 months, with no signs of hyper or hypothyroidism.
You have already told this. According to this history, what do you think? That's all you have to mention. So what it is? It's a thyroid swelling?
Yes, ma'am. It's a thyroid swelling. 15 into 8 centimeters.
No,
No,
that
don't
is not
mention the
important.
size.
Okay. Thyroid swelling in
Probably.
euthyroid state, ma'am. In
Probably
euthyroid
what?
state. Probably multinodal, probably malignant also, because there is a worsening of nervousness. So
No, I think you
probably
can very
malignant.
boldly say that you are suspecting a malignant transformation. You can say that.
Yes.
With all this,
Yes.
you can.
Yes.
That's true. It's a long-standing swelling for last 5 years. Probably for last 4-5 months, it's turning into malignancy.
Suppose
Okay.
I ask you this question, Yasaswini, at this
Yes,
stage,
sir.
what are the strong things you can suspect in this patient that it is probably malignancy, other than rapid increase in the hoarseness of the voice?
The age also, sir, and the
Yes.
Secondary age, correct. Number 2. Number 2,
the size of the swelling, sir. It is
very
a
good.
comparatively
Larger
large
size.
swelling.
Larger size. And number 3, good. Yes.
It is
Remember,
since long standing.
no,
5 years.
number, these are not the full proof, as I already told you.
Yes.
Rapid increase in hoarseness is definitely we have to keep it in mind. But again, man. So men.
Yes, sir. Man, yes, sir.
You have a man here. You have a man
Yes, sir.
here. Elderly age group is there. Very large size. More than, according to it's 15. So it's almost like transverse diameter. They're called giant quadrants. When they have, so there's almost like 10 to 20% more incidence of malignancy. So that's how you can tell in the exam. Yes, sir. Please proceed.
Only thing, you don't mention no signs of hyper or hypothyroidism with no apparent symptoms of hyper or hypothyroidism. Okay, you can proceed with the examination.
Coming to general physical examination, we have an elderly male patient. He is a moderately built and nourished, conscious, calm, cooperative, and oriented time-facing person. There is no pallor, icterus, cyanosis, clubbing, fetal edema, or generalized lymphadenopathy. His weight is 64 kg and his BMI is 21. Pulse rate, the pulse rate was 78 beats per minute. It was normal in rate, rhythm, character, volume, and condition of the reservoir. Blood pressure is 130 mm per on right upper limb in the sitting position. Respiratory rate was 16 cycles per minute and he was injured. Local examination. The patient was examined in a well-lit room in sitting position with adequate exposure. There is a solitary horizontally oval swelling of size 15 into 8 centimeters noted in the anterior aspect of neck. It moves with deglutition. It is extending beyond the posterior border of sternocleidomastoid on the right side up to the anterior border of sternocleidomastoid on the left side, superiorly extending into the thyroid cartilage, and inferior border is not visible even on deglutition. Right side sternocleidomastoid was pushed lateral. Surface was uneven, it was lobular, and prominent dilated veins were present over the swelling. Trial sign was positive, and Pemberton sign is also positive. There were no other visible swellings in the material. Here we can see that trial sign is positive. On the side that the trachea is deviated, we can see that there is a sternocleidomastoid, medial head is prominent, and Pemberton sign after this patient lifted his hands above his shoulders and above his heads when his arms were touching his ears. There was dilated and enlarged veins over the neck region and mildly extending into the thoracic region also. And there was visible congestion over the face. The patient's palpation. Patient neck is slightly flexed and examined from there. There was no local rise of temperature and tenderness was also absent. All inspected findings were confirmed. Solitary swelling with irregular shape of size 15 into 8 centimeters was noted in the anterior aspect of the neck. It moves with deglutition. It is extending beyond the posterior border of the sternocleidomastoid on the right side and up to the anterior border of the sternocleidomastoid on the left side. Superiorly, it extended up to the thyroid cartilage and inferior border was not found. Surface of the swelling was uneven, it was lobular and prominent dilated veins was present over the swelling. And all the borders were felt except the inferior border, which was not palpable even in deglutition. There was mobility present in the horizontal and the vertical. Coach's test was negative. The bilateral cavities were palpable and there was no thrill. The lymph nodes, there were no cervical lymph nodes. Percussion. On percussion, there was a dull note or mandibular stimulus. auscultation, there was no breathing out, and there was no breathing.
Okay, go ahead. Finish your examination, systemic examination.
Systemic examination, respiratory system, there was bilateral equal air entry, vesicular blood sounds were heard, and there were no threats. So cardiovascular system, S1, S2 were heard, and the nervous system was heard. For abdomen, there was no abdomen. Central nervous system, the internal reflexes were normal, and there were no eye signs suggesting thyroid.
Okay. Your diagnosis.
The diagnosis I would like to make is a 65-year-old male with retrosternal extension in the euthyroid state with recurrent laryngeal non-buoyancy, which is probably of monocytic inflammation.
Go to inspection, madam. Inspection slide. Yes, sir. Faculty can proceed with the questions.
Anterior border. Yeah, right. Laterally. Okay. What is, I mean, just for the sake of asking, what does this Pemberton sign indicate?
So, Pemberton sign, basically, if there is
And
a
what is the basis of doing this Pemberton sign?
Pemberton sign indicates whether there is a retrosternal extension of the thyroid spheroids. The basis of doing this sign is when the thoracic inlet great vessels are obstructed, or when they're compressed, there will be dilation and engorgement of the veins. So when the patient is asked to lift his hands up above his head, you can see that there is engorged veins over his neck and anterior part of the thorax regions. And there would be congestion of his face also. And in some cases, he could have also had respiratory distress.
So can you tell me the mechanism why these veins gets dilated on raising the hand?
Ma'am, basically, on raising the hand, the thoracic inlet becomes smaller. This will cause compression over the great vessels, which will cause its tributaries to have increased pressure.
Any specific vessel is mentioned which gets
superior vena cava.
See, already there is a retrosternal extension is there, which is entering into the superior mediastinum. And while raising the arm above the head, you are narrowing the inlet portion. So there is more compression on the veins.
Yes,
right? So that's why these veins becomes dilated over the neck and chest.
Yes. Yashaswini, just adding on to whatever has been told to you, can you just tell me actually how exactly the hand is raised above the head? What originally Pemberton described, just for a yes, tell.
Yes, sir. So it should be raised above the head, sir. His arms should be touching the sides of his ears, sir.
So just for the benefit of everyone here,
Yes, sir.
Forward 100. I don't have to ask you to demonstrate. Just
Yes,
for the sake of what is shoulder flexion? You know, raising the hand forward. Forward means anterior. Anteriorly 180 degree touching the ear. So what are the 2 or 3 things? Suppose you may see it's very well and good. Anything else? Anything else you want to watch?
So congestion over the face and respiratory distress also sometimes.
Some kind of a bluish cyanosis, congestion, puffiness, some edema, and veins. If it is present, it is an indication of probably a compression. Yes, retrosternal compression. And trail, just for because since it's a TRAIL, it's sometimes auto gets corrected, not trial. Okay. So why do you get that? Can you show the picture once? Picture. So that I think, yes. No, I think with your cursor, you can tell me where did you see this trail sign?
So the sternocleidomastoid, sir, the medial head of the sternocleidomastoid is more prominent on the left side, sir, here. Whereas on the right side, we cannot see the sternocleidomastoid. So this is the swelling. This
Why?
sternocleidomastoid is pushed laterally, sir.
Yeah, why?
So
Why
this
it
is
become correct? Why it become prominent? Yes.
because of the deviation of trachea to this side, sir. There will be a
Yes. So
there will be a push on the sternocleidomastoid. So this medial head will get more prominent to accommodate them.
those fascia relaxes. So then
Yes,
the
sir.
clavicular head that becomes
sir.
more prominent.
Prominent.
Can you show the trachea?
So the trachea.
Correct. Yes, correct. That's what you can't feel the trachea in front, so that's how you trace it. You can see that prominence. What is the prominence you are showing there?
The thyroid, the cartilage.
Did you mention some veins which are seen even without arms raising? Show. Actually, we can see.
Yes, sir. There are some distended veins, sir, which was seen even without the arms raised. Sir.
What are
these? Sir, this is also a vein, sir.
Prominent, probably anterior jugular veins. So you see such
Yes,
a large one which is compressing there. So whatever you are seeing, this you see that chin is extended, correct? A bit
yes,
chin.
sir.
What happens to the thyroid vein when you? Why do you want patient to extend the chin?
So if he has a short neck or a webbed neck, sometimes the thyroid swelling will not be visible. So sometimes we ask him to extend the neck.
To this, there is some amount of cervical lordosis. You know that it pushes a bit of the the vertebrae and gland, so it becomes more prominent. So this is what you are showing in the classical position. Then that's a trail sign, and then the third. So before you say oval swelling, you have to be a little careful. Can you show me with your cursor on the right side the upper pole of this swelling?
Yes, sir. This is the upper swole.
Now, if you look at that, is it oval?
No, sir. It is not oval exactly, sir.
Because it's very difficult to accept that when you say horizontally oval swelling. You are written there, correct?
Yes.
So what you should tell is, this is not exactly horizontally oval. This is one lobe is enlarged. You can see the upper limit of the lobe, and midline it has crossed almost to the left side, correct?
Yes. Yes.
You don't have to commit yourself. A large swelling which left vertically extending from and horizontally extending. That's all it is. So if you look at that shape, it is not exactly like an oval. Okay. These are just observations, madam. I think somebody can please take. Consistency, I hope you have done only inspection, I suppose.
Yes, sir. This is just inspection.
So what the important causes when you don't see the thyroid gland moving up with the deglutition?
So with the deglutition, if the thyroid swelling is not moving, sir, that means there could be invasion of the fascia, sir, which will cause sometimes, or it could be a very large swelling, which.
Don't say invasion of fascia. What you should know, what is that fascia? Which fascia?
Pretracheal fascia.
That is not the cause.
A large swelling could also sometimes.
Mechanical obstruction is one possibility. Huge goiter. There's no place at all. Anything retrosternal is something which we are discussing. Anything else? You said fascia, correct, but it is more of a posteriorly. What is the fascia which is behind? Where usually this anaplastics infiltrate, just makes it inoperable. You can't remove it. Behind. In front of. Yes.
Sir is asking both mobility is restricted.
Correct.
In both horizontal and as well as in which condition? Which fascia it is? It is a part of deep cervical investing layer only. What is that fascia?
Okay. Behind. So in front of vertebrae. So it has to be.
already has given clue.
Prevertebral.
Yes.
Prevertebral.
See, so pretracheal fascia, it does not make it that, so basically prevertebral fascia infiltration, then fixed to the, trachea, all these advanced stages, large size, very big one. So, and of course, you have already told the retrosternum. So this has to be kept in mind whenever you have a patient where you say that, it cannot move with the deglutition.
Yasaswini, you can go to, if
Yes.
there are no more questions, we'll go to palpation, sir.
Yes, definitely.
Just for the completion's sake, what are the other swellings in the neck which move up with the deglutition other than goiters?
Other than goiters, there could be thyroglossus cyst that also moves with deglutition, subhyoid bursitis, any pre-laryngeal or pretracheal lymph nodes, sometimes also move with deglutition.
Should we move to the palpation, sir? Metgud,
Yes, sir. Yes, sir.
Yeah,
Yes, sir.
definitely.
Yes, madam. Palpatory slide, madam. What is the consistency, madam, across?
So consistency, it is firm in consistency, sir. The swelling is
Uniformly
firm
firm?
yes, sir, uniformly firm consistency, sir.
Okay. Can you name some conditions where it is hard? Thyroid swellings,
So,
thyroid
it
nodules
is hard.
are hard in consistency.
Yes, sir. In Riddle's thyroiditis, thyroid nodules, thyroid swelling will be hard, sir. And even in malignant, like anaplastic carcinoma, also we find that the thyroid swelling is hard, sir.
Any chances where there can be calcification?
Yes, sir. Long-standing cyst also can get calcified, so that can also.
Okay.
Yasaswini, one important thing, this is for everyone. Whenever we talk this diameter, especially anywhere in the body, once you comment say 15/8, you can't say it is understood. You have to tell what is vertical, what is horizontal. Because this has got a bearing in many situations. Even in the abdomen, you have a palpable large gallbladder. Vertical it is more than horizontal. Thyroglossus cyst, even a one lobe of the thyroid. So you have to make yourself very clear. So what is this 15? What you are referring to is 15?
Horizontal, the horizontal diameter of the swelling.
From where to where?
From the posterior aspect of the cemetery, the side till the anterior of the stomach.
Can't hear you actually. Yes, can you? Yes.
It was present from the posterior border of sternocleidomastoid on the right side, so till anterior border of the sternocleidomastoid on the left side. The largest diameter is 15 centimeters.
You said here upper border you can make out and it is up to the thyroid
Up to
cartilage.
thyroid cartilage.
So do you think it can go beyond and go to hyoid bone, etc.?
No, sir. I think that it can only extend up till the upper border of the thyroid cartilage, sir, because the
Yes.
Origin of this, the insertion of the strap muscles would be there, so it will not.
Anything else? Any attachment? Yes.
Yes, sir. The Berry's ligament, the attachment of Berry's ligament, pretracheal fascia will be condensed there, so it will not cross more veins.
Don't. Where is Berry's ligament attached? Why did you bring that?
So it is the condensation of pretracheal fascia.
Yeah. Since you mentioned, where is the attachment of Berry's ligament? To above or to below? Below means to the cricoid cartilage. You understand?
Yes,
And tracheal rings. Not
Yes,
go above. Why it is going behind the sternum here? You can't feel the lower border, right? Why?
Yes, sir. So
Why?
because sometimes when the thyroid extends inferiorly, it extends below the sternum, sir.
Not below, you say behind. Behind
the sternum.
Why? See, there's an important. Yes, go ahead.
Because of negative intrathoracic.
No, that is the mechanism of retrosternal goiter formation. But why does it go behind?
So, sternum is relatively anterior, sir. It will, narrow swelling will not.
Okay, I will ask you one question. What is the lower attachment of pretracheal fascia? That will give your answer.
So,
Lower attachment. That is why
the,
yes, go ahead.
the
It blends with the advantage of the arch of the aorta. So it
Yes.
becomes low down. That's why as it enlarges, then it becomes. So that explanation you gave, negative pressure and all that thing, that we'll ask you later. Okay, sir. I think you can. Anything else, sir? Metgud,
Yeah,
anything?
sir, I think it's important that they tell us like the position in which the inspection was done and palpation is done,
Yes.
whether
Yes.
it is done from front or back. I think that is better mentioned.
He has mentioned from behind.
Mentioned, sir.
Oh,
Mentioned.
sorry, sorry, I did see that. Sorry.
Yes, sir. She has
Sorry.
the palpation, patient neck flexed and examined from behind.
Yeah.
Yes.
Yeah, it's mentioned, sir. It's mentioned.
Yes.
Assistant, you can move to the next slide.
Yes. Yes.
Okay, what do you mean by mobility present in horizontal and vertical plane? How you could elicit the mobility
So,
in
in
a
vertical
patient
plane,
whom you couldn't feel the lower border? How you could appreciate the mobility in vertical plane?
so the upper border moves, sir, with the deglutition, and
No, it is moving with the underlying trachea and larynx.
yes, sir. And
When you say
horizontally
mobility
also,
present, could you
Yes, sir.
fix the swelling and move it horizontally?
No, sir. We can't fix the swelling and move it horizontally.
Yeah,
With the
because
trachea, with the attachment.
Okay, it so happens that this thyroid swelling, they always move with the underlying trachea and larynx, either vertically or horizontally.
Yes.
Okay.
This is one common mistake done when you have a huge multinodular goiter. Don't say this statement. You cannot move them independently. They move with the trachea. The whole complex moves. But you have one small nodule, which is undergoing malignancy or something. Then that relevance will come. I think, Dr. Patil, so is it a correct explanation?
Yes, sir. I agree with you, sir.
Because
in this patient, small nodules sometimes are small cysts. Maybe will be able to move in thin individuals with thin neck. But such large swellings, I think it is difficult, and that too here we are not able to palpate the lower border.
Yes, sir.
Okay. Can you just tell us what is Koch's test?
Conscious test basically on general compression on the lateral lobes of the thyroid. You can hear striders. Patient
What exactly you do, madam? Can you repeat?
Gentle compression on the lateral lobes of the thyroid, sir.
What you're doing
that
when
will,
you press?
That will compress the trachea, sir, and it will induce a stridor, sir. The patient is asked to take deep breaths, so that will induce a stridor in the patient, sir.
Okay, so this is more of a subjective test, madam. Gentle means how gentle you are, how harsh you are, how much medially you are going to compress, and it also depends on the duration of the swellings.
Yes.
Okay.
Yes,
so because this swelling is there for last 5 years, quite a big swelling, these patients are also likely to have some amount of tracheomalacia. Sir, I just Rajgopal Shenoy, sir. Shenoy, sir.
Yes, sir. I'm here.
I just want you to clarify about this Koch's test to the all the postgraduate students, sir, because how gentle you are, how harsh you are, it is all more of a subjective test. Can you just?
I know, sir. I don't want to, because what happens is we all follow, that's whatever method, the theoretical methods. So these are given in the books, but today most of the examiners don't expect you to do such things, especially in a large goiters like this, because the problem of Koch's test happens only in a large goiter, correct? When you have a both side compression. And this you can't really do a slight compression. So so when you put a little more harsh, means anybody will become having a.
Exactly, sir.
So,
I also.
so one other examiner asked me, when exactly you are written your focus test, if you produce more compression, you get stridor. This happens when preoperative or post-operative. That you should know. Preoperative or post-operative. You know, you are going to remove the entire thyroid, correct?
Yes, sir.
What will happen to the trachea at that time?
So basically, if in case of long-standing thyroid swelling and we remove the thyroid swelling, so there could be some amount of tracheomalacia, and that could cause perhaps like.
In fact, the thyroid is keeping the
trachea open. Yes.
Open.
Collapses.
Once you remove it, it collapses. That's what happens. So the importance of that was for this reason. So gentle compression, that's what it is. So I think if examiner asks, we should be able to say that. That's also.
Yes. It can lead to emergency, medical emergency, no sir, if it is stridor occurs, whether it is to be done or not. Shenoy sir.
What does that mean? Sir,
it can lead to medical emergency, like a large goiter, like stridor if we are inducing. It's like a medical emergency we are inducing. Definitely. So whether it is to be done or not.
Definitely, madam. Intubation and intubation, ventilation, and prepare and do the surgery. Yes, definitely, madam. Yes.
Okay, which cervical lymph nodes you have palpated, madam, and why you have palpated in this patient?
In this,
Patil sir, just before that, just want to ask about these carotids. Are they felt normally or have they been pushed?
Sir, they were pushed actually, sir. They were felt, but they were pushed laterally. Sir.
You have to mention that, Dr. Yasaswini.
That is an important finding, no? So you'll have to mention that.
Yes.
Sir, to be clear, they are pushed posterolaterally.
Yes.
Yeah, posterolaterally.
And see, Yasaswini, what is important in the PG? You are a PG, so undergraduate, it's okay. You have to, whatever you are not written is not done. That's how it is. So that's why he asked you that question. Bilateral carotids palpable. Firstly, where it is palpable. Normally, where it is palpable. So you have felt it, whatever, posterolateral. So it is pushed, right? So what happens if you suspect malignancy? These are the questions which will follow.
In case of malignancy, due to invasion of the carotid sheath, it will not be felt.
Using the word invasion, better you say infiltration.
Infiltration of carotid the sheaths.
Carotid sheath. What is the difference between infiltration of carotid sheath and infiltration of carotid?
So carotid sheath is covering. So it is not yet.
How will you make out that? This is one question they will ask you. It is basically engulfment of the carotid sheath. So the lumen is intact. So what do you feel? What do you feel in the face?
Which is the last branch?
Branch of.
Yes, sir. The superior thyroid. The superior.
No.
In front of tragus man.
Yes.
Yes, sir.
What branch? Terminal branch.
So
of external carotid.
Take your time. You will answer. Slow. Don't look at this side, that side. If you superficial temporal artery. So you
superficial temporal
artery is still palpable, but in the neck, it is not. Here you don't get. So that's the importance of this carotid. What has been called as Maris sign. Okay, all right. Anything else?
Yes, ma'am. I think you can proceed to your diagnosis. Already I've told your diagnosis.
Sir, there was a question asked. What were lymph nodes to be felt and what levels?
Yes. Yes. Can you answer that? Yes.
Yes, sir. Basically, the thyroid invasion will first occur in the level 6 and the delphin and the level 7, first level 6 lymph nodes. But what we feel is the level 2, 3, and the 4 levels of lymph nodes along the standard the internal jugular vein. Deep cervical lymph nodes are there.
There are level 6 nodes also.
Yes, sir. Level 6 nodes also are present.
Level 7 also, which we
Level
don't
7
feel.
mediastinal lymph nodes.
Yeah, we don't feel. Okay.
In a simple one sentence, I look for jugular lymphadenopathy. You tell the nomenclature, the levels came, but just easy to remember. Instead of trying to say along the length of sternomastoid or something, jugular lymphadenopathy. That's what is your 2, 3, 4, and then behind and infant. And do you know any peculiarities? Especially, you suspect a papillary carcinoma. Obviously, lymph nodes are there. What do you think? How they are different from, let us say, carcinoma tongue with the nodes, or buccal mucosa and nodes? Anything? Any peculiarities? Especially papillary in a younger patients. Yes.
The regions along
You will get greenish fluid when you aspirate. That gives you a hint.
So importantly, more than the time, they are just the clinical side. They can be soft, they can be cystic, they can be hard, they can be single, they can be large, they can be long duration. You can have a lymphnodal secondary for 2 years duration, 3 years duration, 4 years duration, and thyroid may not be enlarged at all, occult primary.
Yes,
so there are some 6, 7 criteria. So it's important. You have to have a high degree of suspicion. Younger patient coming and with a small swelling there. Yes, when you aspirate, definitely you will get a some kind of a altered, this colored like thing. Because papillae have a little bit of thin papillae in papillary carcinoma. There's a rupture and causing a little bit of slight brownish type of red color. That's the reason. Yes.
What is lateral aberrant thyroid?
Yes.
Lateral aberrant thyroid is when there is a no significant swelling in the thyroid region, but the lymph nodes are enlarged. So,
Laterally, you don't find thyroid tissues. If you find lymph nodes, if you find thyroid tissue in the lateral aspect of the neck,
aspect of the neck.
they are due to
papillary
any thyroid carcinoma which can metastasize. Mainly, usually papillary carcinoma, because it can present with occult primary. How does it spread to the deep cervical nodes in the level 5? Because as you said, level 2, level 3, level 4, and level 6.
Yes,
But sometimes it goes to level 5 directly. I will give you the answer. You know that inferior thyroid artery is a branch of thyrocervical trunk, which also gives rise to the suprascapular artery. Okay. Along those lymphatics, it spreads in the retrograde direction.
Can we go to the diagnosis, Dr. Yasaswini? If you're done with your, percussion and
if there is no retrosternal extension, should we need to percuss on the manubrium sterni? If the lower limit is, you are able to feel the lower limit.
If the lower limit is felt, then there is probably no retrosternal extension, sir. But in case of, if there are lymph nodes palpable, if there are any
lymph nodes are not palpable, lymph nodes can be metastasized to the superior mediastinal region. Enlarged nodes. You cannot feel them, but they generally are small. You have a trachea which is resonant there. Only when there is retrosternal extension, it may go up to the carina, means just above the carina, left or right main stem bronchus. So there may be a dull knot.
Okay, madam, you can go ahead with your diagnosis. Already I've told the diagnosis. Go to the diagnosis slide. Systemic examination, everything is normal.
Yes, sir. Everything is done.
Okay, fine. Your diagnosis? Okay, your diagnosis is MNG with retrosternal extension, clinically euthyroid, probably of malignant
Malignant
etiology.
etiology.
When you write malignant, don't write goiter, multinodular goiter.
See, how are you sure that it's a recurrent laminal paralysis? So it's better that, that let the examiner ask you that question. You understand, no?
Yes.
Hoarseness can be due to several factors. Somebody has got laryngitis also, they will have some problems. So it's better that hold on to that. What your diagnosis is definitely a retrosternal goiter. Why do you say retrosternal goiter?
So because Pemberton in the first, the low inferior inferior border was not palpable. Then Pemberton sign was
So at least to say, of course, that we'll talk only little later too, but just to complete that, by definition, minimum how much should be there behind the sternum to say that it is a retrosternal, at least.
At least 2 centimeters.
50%.
Yes, percentage-wise, it should be there. So anyway, that is a little beyond our at this juncture. But you have to only say that most probable diagnosis is retrosternal goiter. So it's you are telling about multinodular goiter, but then you are talking probable malignant etiology. So you can say that.
You can write malignant transformation in a multinodular goiter.
It's difficult at this juncture.
Correct.
If they ask you what is the cause of hoarseness, then you substantiate and say, why I suspect? Because of this record, I suspect. That's why.
Because multinodular goiter, whatever size it reaches, it will not infiltrate the nerve. Because it is a slow process.
If the question is asked by the examiners, why did you suspect a malignancy? I'll quickly, because the time, whatever. History-wise.
Yes, sir. History-wise, because of age.
Please go ahead. Please go ahead.
Yes, sir. History-wise, there is age, there is gender, and there is rapid increase in the size in the last 6 months with the hoarseness of voice. And clinically, because clinically, because of the laryngeal.
Clinically, because of size, really.
Size, the size of the size.
Because you never said any hardness. Of course, hard.
Yes,
You get always hard swelling, but never said any hard, irregular.
This regarding the consistency, sir, I think they should know about the thyroid paradox.
Yes.
Yeah, can you tell us what is that thyroid paradox which we all talk about? Cellular neoplasms are usually?
In case of papillary thyroid carcinoma, it is soft, so the consistency.
No, papillary carcinoma are not soft. Follicular will be soft. Ardal cell can be soft. Papillary and medullary thyroid carcinoma can be hard nodules also because there are some calcifications. There will be multiple nodules. Papillary carcinoma can be multiple. Follicular can be single. Anaplastic is usually hard and fixed. It is the one which grows fast. The other malignancies usually don't grow fast. What malignancy histology usually arises from a long-standing multinodular goiter? Follicular carcinoma. But if it is a Hashimoto's disease, Hashimoto's thyroiditis, lymphocytic thyroiditis, it can be lymphoma.
Yes.
Lymphoma.
Yes.
Should we proceed to the workup of the patient, sir?
Yeah, yes, sir.
Yeah, yes, ma'am. We can go ahead with the investigation. So your diagnosis is a large goiter, retrosternal extension, probably going in for malignancy, right?
Yes,
Yeah,
sir.
go ahead with your investigations.
Hemoglobin, investigation, complete blood
Don't
count of the
read.
patient.
Only the abnormal.
Don't read all the things which are very important, relevant only you say, otherwise essentially normal. So, please.
Complete blood count was normal, sir. Renal function test also was normal. Thyroid function test was also normal. This patient.
So I just want to ask you one important question. When a patient with the carcinoma of the breast comes to the outpatient department and you have made a diagnosis, if the examiner asks you what next, what is your answer?
If a patient come of carcinoma, thyroid, sir,
Carcinoma of breast.
with the thyroid, if they come to the
After your examination, what is the next test you would like to do? Is that called circle?
Venkatachal, little different. What is the next thing you will tell the examiners? Let us say in the OPD she has come. So
yes, sir. Investigation, how to
better that you please use the word triple assessment, correct?
yes, sir. Yes, sir.
So this is the we expect every postgraduate to know what is triple assessment. Now I'll give a clue to you and take up this answer here. So it is triple or something else is there? Yes. Go ahead.
Yes, sir. So I didn't understand your question.
See, triple assessment, sir is telling. What is triple assessment in diagnosis?
Breast.
Thyroid function test, USG of the neck.
In breast, what is triple assessment?
Limb.
Clinical examination is over.
Yes, sir.
Clinical examination.
Sonomammography.
No, radiology.
Yes, sir. Sonomammography. Then FNS.
Pathology.
Yes, sir. Pathology.
So now you answer for thyroid.
For biochemical investigation, I have chosen thyroid function test. Sir.
That's okay. What?
Now we will want to get the USG of the neck, sir.
And
yes.
USG of the, and then USG guided FNAC of the swelling.
Correct. So
USG?
clinical examination, T3, T4, that's the functional aspects. Then comes the image. In the breast, it is a mammogram. Here it is ultrasound. And in the breast, it is core needle. And here it is. So that will be the correct thing you should tell in the examination to proceed when the examiner asks. Please go ahead with that. Is what has been done. Next question.
Proceed with the other investigations, madam. Yeah.
Yes, sir. FNAC was done, sir, initially. There was 3 ml of thick brown fluid was aspirated. Multiple smears showed scanty cellularity comprised of many cyst macrophages along with few scattered degenerated follicular cells. Background shows thin colloid mixed with RBCs. Impression with features of benign thyroid nodules suggesting cystic nodular goiter. According to the Bethesda system of reporting of thyroid cytopathy, this is grade 2.
So what does it tell you Bethesda 2 means?
Bethesda 2 means that it is a non-neoplastic cystic.
So non-neoplastic, would you like to send the patient home? Tell that you don't require surgery? No. So why? So now it becomes an important issue here that what are the indications after this step onwards? So you have done the ultrasound. You have done the clinical examination is over, biochemical over, ultrasound, FNAC done. So my question to you is, you aspirated that fluid. So after the aspiration, is the size came down? Next question. No. So now the Bethesda 2 here. So what are the indications now? For surgery, obviously.
So did we get to see the ultrasound report, sir?
Is there?
No, sir. In this patient, ultrasound.
You have done the CT scan, huh? So
Yes, sir. CT scan we have done.
Generally, in malignancies, we don't use iodine contrast or
Yes, sir.
if we suspect malignancy. So alternative would be MRI, better option. What imaging was done, please?
CT scan was done, sir. Of the neck. Non-contrast CT scan was done, sir.
Read about the report, madam.
Yes, sir. Right lobe of the thyroid shows large cystic lesion. It is exophytic in nature and extended to involve the isthmus. Peripheral calcification is noted. The lesion measures about 70 to 65 mm in size. Significant mass effect on the trachea was seen, which is pushed to the left side. Inferiorly, the lesion was extending up to the retrosternal region of the sternum. There was no significant cervical opening.
Kindly show the other view. Other view.
So only one view is there. We have only this picture.
So I would like to ask you one question again, the same question which I asked you. So what is the indication? I think postgraduate should know very clearly now at this stage, even though it's told to. So let us forget about malignancy at this juncture because of this FNS you have done and all these things. They are given choroid goiter. So my question to you is, is there absolute indication in this patient?
So in case of a retrosternal goiter, it will not be able to visualize on USG. So we will need to go to CT scan to see the extent of.
No, I didn't ask you. Your answer should be retrosternal compression.
Yes, sir.
That is the important indication.
Yes.
That's an important indication. That should be your answer, even though it's called choroid goiter. So in general, what are the indications for surgery?
If there are compression symptoms like dyspnea, if there is dysphagia,
Cosmetic compression.
Cosmetic,
And
yes.
what is the nodule size? Any criteria you know?
uh,
Nodule size.
more than 4 centimeters
4
size.
So what is your case? Almost big size.
Yes, sir.
Cosmetic, everything is there. So that's what answer I expected, in spite of your Bethesda 2. More than anything here, retrosternal is the main issue. Okay, yes. Sir, anything from other exam?
See, your diagnosis clinically was malignancy, malignant transformation. FNAC was not conclusive.
Yes.
Would a core biopsy have helped, or would you do a core biopsy?
So core biopsy is only done in anaplastic carcinoma. Otherwise, we do not do core biopsy because the
Yeah. So,
the
what are the
very
reasons
vascular.
why core biopsy is usually avoided?
So in this case, the thyroid gland is very vascular, sir. So this is why we avoid core biopsy unless we are suspecting anaplastic carcinoma.
You will get only colloid mainly because it is cystic degeneration also colloid.
Even the
Vascularity
and nerve injuries are the reasons why you don't do a core biopsy.
It's a good question, sir, Dr. Metgud. This is an important thing, especially we just tend to, even in moment you say FNS negative, they tend to tell this. So now, what are the other indications for core needle other than this anaplastic?
Plastic.
So to differentiate between
Differentiate.
so
What are the
sometimes
Other indications apart from
Sometimes-
anaplastic carcinoma, what are the other thyroid conditions where core biopsy can be done or is indicated?
malignant lymphoma.
Yes.
Malignant lymphoma is also one of the
Yes.
Anaplastic
lymphoma.
yes.
Don't say malignant lymphoma, just lymphoma.
Yes, sir. I think
Yes, ma'am. You can go ahead. What other investigations are done in this patient apart from this?
X-ray of the neck was done, sir. Anterior posterior view showed deviation of the trachea to the left side, sir. You can see the deviation of trachea to the left side. Lateral view showed that there was no compression on the trachea and the tracheal rings calcification was seen.
No,
So you mean
once
to say
the
this
anteroposterior
patient-
view has shown deviation, how can you say there is no compression? There is a deviation, there is a compression. You can see in the anteroposterior
It
view.
is, but It is still patent.
Patent, it is
Narrowing.
clearly seen in both the views, but there is a compression. You can see the lumen being narrowed in the antral.
So these are the patients when they sleep to one side, specifically one side, when they turn with the gland like that, no, especially here.
False.
This is what they get a little bit of difficulty in breathing. One-sided, that's a postural. Yes, okay. Yes.
Next, madam.
We did chest X-ray, sir. The tracheal deviation was seen, and otherwise the chest X-ray was minimal.
Yeah.
Uh,
So,
This is, yeah, you can just show this video.
Indirect laryngoscopy was done, sir. It showed right level for.
Yasaswini, is that indirect laryngoscopy or video
No, sir.
laryngoscopy?
This is video assisted
Why
laryngoscopy.
did you put
But
a
we did
title?
both. We did
Okay.
both, sir.
Videos.
Yes. So that's why don't by heart the things and go on putting the title. You have done a very nice video laryngoscopy. Okay. That's what is recommended. Yes, go ahead. Next. Yes.
This was done pre-operatively before intubations.
Yes. Okay. Yeah, okay. Got the point.
Okay. What was the plan?
So for this patient, the plan was total thyroidectomy, sir.
Mhm.
Next
A
slide.
total thyroidectomy was done, sir.
No, is it involving both the lobes?
In the CT scan, it showed that it was only involving the right side lobe and extending into the isthmus, sir.
So does she
But,
need a total thyroidectomy?
Uh,
Why did you plan total thyroidectomy here?
because of the age, considering the age, we could FNAC also was not confirmatory, sir. So because of the looking into these factors, we were suspecting that there could be.
Do you have facility for frozen section?
Yes, sir.
Show the next slide.
Frozen section facility was there, sir. So we did total thyroidectomy with frozen section. Here we can see that the current thyroid was there and thyroid was there. The thyroid was operating over there into current direction, and it is extended into the external line. There was stretched out recurrent direction over the level of inferior thyroid artery. The tumor was pulled out without the need of sternal. Frozen section also showed features of colloid butter with no evidence of malignant disease.
What is the risk involved when you are trying to pull out the retrosternal extension part into the neck?
So there could be injury to the recurrent laryngeal. That could be there, sir.
Current laryngeal nerve injury won't happen when you are trying to pull the gland.
There
Something
could be residual disease also.
no residual disease. It is the inferior thyroid veins which may get avulsed and retracted, and then there can be bleeding in the superior mediastinum. Sometimes you may need a manubrious sternotomy to control that.
What were the operative findings, as sir asked why you did total for this patient? So many times we may not get the correct picture by imaging like CT. So when you explored, were there any nodules or disease on the left
Yes,
side
sir.
also?
On the left side, we felt like calcification. We felt, sir, like something hard. We felt
Yeah,
on
because
the left side.
when
So
you
this is-
explore the neck, okay, so clinically or sonologically they might have mentioned normal, but you feel that the other lobe is diseased, then you can
Yes, sir.
change your plan of treatment. So from going from hemi, you may go for subtotal or near total or total thyroidectomy.
In the left lobe of the thyroid, we
Sir,
felt,
if
This is
sir,
the
I think
time
can
this is the time to tell that we have got a very high suspicious malignant case here.
Yes, sir.
Irrespective of the CT scan and FNAC and on-table finding, see, even if a small focus of malignancy is there, unnecessarily so one chance you have got to give a good, after all, at the end of the day, you had require one small dose of L-thyroxine supplement, that too. So I think most of the examiners, PGs nowadays, the expectation is a total thyroidectomy.
And another thing is, sir, frozen section cannot totally rule out or give us the diagnosis. So that's another gray area which we need to look into.
The problem
thing is
happens with
the word tumor pulled out. Maybe the reason why this. So otherwise, most of the 95, even literature goes up to more than that percentage with a good incision. Only you have to plan your incision properly here, and with a good retraction, subcapsular dissection you try to do. Ligate all the vessels. Slowly it will. Generally it comes out. Most of it comes out. So. Do you know any CT classification of the retrosternal goiter? This is just for because management-wise, you'll have a. Do you have Yasaswini? Yes.
Any percentage?
Because
according to CT findings, if it is extending up till the sternal, the manubrium sternum, it is grade 1. It is extending up to the sternum manubrium jaw, then it is grade 2. And if it is extending below the sternum, then it is.
I don't know whether I am hearing properly or not. So it's just too easy to remember. If there's a broad base going down, difficult to deliver it out. If there's a narrow base like a pyramidal thing, it is easy to remove. These are also important. Anyway, these are little beyond your thing to question, but since it's a PG thing, so we keep it in mind all these things before we proceed. So if you get a good assistant to retract and nice, slowly, it will come out, relatively easily. It is rarely a sternotomy is required. Okay.
Where does this retrosternal extension derive its blood supply from?
Most commonly, it will derive its blood supply from the inferior thyroid vessels itself. But sometimes it could also be deriving from the mediastinal vessels also.
That's very, very less. I think more than 90% will be deriving from the thyroid gland itself.
Yes.
Very less.
What you are talking is completely ectopic, ectopic means that primary arising itself from the mediastinal goiter, where there was an ectopic thyroid, not in the neck. Most of it is a neck which is gone down. Yes.
Yes,
So,
madam. You can go. Can you share us the? Sir, if there are no questions, we'll just go for the histopathology report. There's a surprise there.
Yes, sir.
Yes, ma'am. You can go ahead with the.
Yes, sir.
You can just share us about the palsy. What happened after the surgery?
Yes, sir. After the surgery, there was a normalization of the vocal cords, sir. Within 3 weeks, his hoarseness of voice came down, sir.
So important question to you is it that carcinoma which has infiltrated the nerve, or is it compressed
Pressure
behind
symptom.
especially behind the sternum there where it goes down, So right side or left side? Tell me.
So
the recurrent enter the right side? Yes.
So on the left side, the recurrent laryngeal nerve will go below, sir. But in this case, the right side was enlarged, sir. So the compression was also probably.
I can't hear your few words properly, but doesn't matter. The space available, behind the clavicular head here, and that goiter which is so big, especially right close, that is probably where it was compressed.
Compression.
Now it is recovered. That's good for the patient.
Histopath report, madam?
Yes, sir.
Can you just share us the histopath report?
Yes, sir.
Yes.
So, this is a histopathological report, sir. They received a globular thyroid tissue measuring 8 into 6.5 to 4 centimeters. The estimate was 3.5 centimeters.
No, tell us the microscopy and.
Angioinvasion was not identified.
No. You mentioned papillary carcinoma. That you mentioned.
Yes, sir. Features are of papillary carcinoma of the thyroid, sir.
I'd like to ask you only one or two important questions they ask you. You may be, what is the criteria to say it's a papillary carcinoma? It is there in your report.
Yes, sir.
Don't-
The intranuclear inclusions, there could be
Nuclear grooving.
grooving.
Yes,
Yes, sir.
that's why. Because everyone says Samoma body and all. So all this alpha nanny, but yes, good that you nuclear grooving and intranuclear.
Okay.
Dr. Patil, Siddesh has, I think, raised hand. I saw, I don't know, just check because
Yes, sir. He was
Yeah.
he has raised
Good
his
evening. Good evening.
Siddesh.
And I just wanted to say good presentation, very good discussion, high level, basic doubts very well cleared by the experienced examiners. I should compliment the presenter also. But my points were, if you want to do a total thyroidectomy for a benign disease or a nodule in question, whether it's malignancy, you are justified when you are confident of saving the nerves, both the sides, as well as at least identifying the parathyroids and preserving. So if you are confident of that, I think that is the basic thing to have an answer that you go ahead with total thyroidectomy. That is one aspect without, of course, casting aspiration on anybody who can. Of course, today with the modern technology of bipolars, energy goods, energy sources available and operating loops, one should be able to do that. Regarding the retrosternal goiter, I think the earlier nomenclature of substernal plunging, all that is gone now. We classify them depending on the degrees. I think it is only the degree fourth degree where we can, it is touching totally majority of the gland is intrathoracic and it is very close to the major vessels. It will require a thoracotomy. Otherwise, the lesser grades can be subjected with only neck, managed with neck incision, which has been already told. Regarding frozen section, I think it has been aptly well covered. It cannot be 100% true, like because there can be multicentricity where we can miss out a part where the frozen is being done on the section, because frozen is done in a short period where we are waiting or keeping the wound open. We may not be able to get the accuracy to that extent, like in breast. That's what my point is. Anyway, otherwise, very good, very well covered. Thank you very much for giving me opportunity.
Thank you, sir. Thank you for your inputs. Yes, ma'am. The report has come as papillary carcinoma. Yeah. So what's your plan of action next? What was planned? What happened to this patient later? How many months or years since the surgery was done?
So basically, it's been already 1.5 years since the surgery was done.
No, that's okay. Just quickly you tell.
Next slide.
After that, that's papillary carcinoma has come. So it's a low grade, whatever written. So what is that immediate thing? Would you like to start him on thyroxine immediately? You are written that 200 micrograms.
Yes,
or would you like to do any radio
iodine?
Yes, please
So
go ahead.
initially we wanted to do radio iodine ablation therapy, sir. But the patient was not willing, sir, for the same.
Because why I say this, because even though surgeons
we should not start
have done total thyroidectomy, we all claim and say boldly, and we say we have done total thyroidectomy. Everything I have cleared, but there can be always a residual lesion that nuclear medicine people will pick up. So then they will tell. So we can't say I have done 100%. So that's why
there can be residual disease in the neck as well as in the lung or other parts of the body. Bones.
Radio remnant ablation. For that purpose, you need that. Anyway, advised. So please go ahead. Whatever you want.
So we had advised a radio iodine ablation, sir, for the patient, but the patient was not willing for it, sir, which is why we put him on suppressive therapy or
that is very convincing.
Sir, Venkatesh sir, the report put up is thyroglobulin level normal.
That may be immediately, sir.
No.
Every 3.
Normal means every 3 months because they are suppressed the TSH with Eltroxin 200. So TSH will generally be low and thyroglobulin will not be detectable.
No,
Or
that's what it should be.
normal
No,
range
it
is
cannot
actually
be
more
no.
than 3, sir, something. So if they write it normal means there is some elevation.
That's what
We
I'm trying
expect
to say.
less than 0.5 or something.
It should be less. It should be
Less.
negligible.
Yes.
Normal, not in a case of patient with thyroid cancer, as post thyroidectomy only, sir.
Yes.
Even the T3, T4, the TSH was below normal range, below normal, and thyroglobulin level also was according to the
We
What
expect
is-
thyroglobulin to be less than 2. Anything more than 2 on TSH suppression which warrants investigation, a scan. Anything above 9, even without suppression, means warrants investigation.
Tejaswini,
Yes,
hello.
yes, sir, yes, sir.
What is this concept of micropapillary carcinoma? Role of lymph node dissection in micropapillary carcinoma.
So, micropapillary carcinoma is basically when the size of the tumor is less than 10 mm of size, sir. That we call as microcarcinoma. In this case, total thyroidectomy can be done, sir, but lymph node dissection is not necessary because we can give a radioiodine ablation post and we can do regular checks of thyroglobulin levels to see if there is any recurrence, and regular USGs once in 6 months to see if there are any lymph nodes.
Yashaswini, I have a question.
School of thought is it all depends on the grade of the tumor, age of the patient, and the risk factors, whether the patient is in low risk or high risk.
High risk.
If patient is in high risk, you have to go for central nodal dissection. Then, depending on the residual disease, you'll have to go for radioiodine ablative therapy. That is the school, because you need to consider the other factors also. If it is low risk, well differentiated, with no positive nodes on ultrasound, you can always keep a watch, and also you need to keep in mind the age of the patient and other considerations. What is vanishing tumor, madam? Any idea you heard about vanishing tumor?
Vanishing tumor.
They had some power failure or what?
Yeah.
we can look.
Vanishing tumor you heard, madam?
Yes, a vanishing tumor. I have heard, sir. Basically,
Okay, if you're not aware, it had come in journal, 2-3 journals it has come. The FNAC will pick up the tumor, and the histopath, cytologist will report it as papillary carcinoma. You proceed with the definitive surgery like total or lobectomy or hemithyrectomy, and the histopath is negative. So you cannot doubt the cytopathologist, but there are instances, and it is an entity which is called as vanishing tumor, and many of them are, papillary carcinoma of thyroid. So there's no role of further surgery in these patients where there is a vanishing tumor. So you can be conservative in your surgery. Yes, sir. Shenoy sir and other faculty can ask questions.
Sir, can I just ask one doubt? See, what I do when you get a histology or you're suspecting malignancy after doing total thyroidectomy, I don't start the patient on Eltroxin. I will wait for the patient to become hypothyroid and estimate the thyroglobulin level. And then I will subject this patient for radioiodine scan, depending on what is the indication. Because otherwise, if you have started the patient on Eltroxin, then you need to do a radioiodine scan at a subsequent date. Then we need to stop the Eltroxin and again wait for 3 weeks. Venki, I want you to please let me know.
Sir, we want the TSH to be at least 25.
That's right. That's right.
For a good radioactive iodine uptake.
So I don't start patients when you are doing on a malignancy immediate post-op period on Eltroxin. I will wait for this whether there is an indication for radioiodine scan and also treatment subsequently. So this is my approach. I think we
Usually
need to
in
have
3
some
weeks, sir, it
Yes.
reaches 25. Usually, if you have starved the patient of L-Troxin and iodine restricted diet like salt and seafood mainly. If you can restrict those two things.
These are TSH dependent tumors. So when it comes to the well differentiated carcinoma, that is a routine which is followed. But probably I understand here you got the report of frozen also colloid, and then
Yes, sir.
and patient has radioisotope scan advice and he was not willing or whatever it is. So maybe the reason. So otherwise, that is just if you are asked a PG, you should tell that immediately after once your report is available 4 weeks later. That's what is the usually you should be starving for iodine uptake, starving.
Yes, sir.
So that is the time you do this scan and then ablate it, and following which what next after the
After the radio iodine ablation, sir, we will see if there are, we will not give L-thyroxine therapy, sir. If we are going for radio iodine ablation.
No, after the ablation, you have to give thyroxine.
no?
Yes, sir. No, if we are planning for radio iodine
That's
ablation.
over.
we will
After
give-
3 weeks, we have
Yes,
done
sir.
the scan. There is some residual disease usually found in the thyroid, but because that of the ITSH,
Yes,
okay,
sir.
some bits of tissues like grass, shaved grass, will be on the trachea. They will
Yes,
grow up, they will be ablated with around 30 millicuries of iodine. After that, you are going to put the patient on a regular diet
L,
with,
yes, sir.
depending on the
L-thyroxine,
body
sir.
weight, 150 to 200 micrograms of thyroxine. Actually, the dose varies with the stage of the disease.
Yes,
Maybe it's too much for you, but we usually put around 150 to 200 micrograms and then titrate the dose by around 8 weeks by doing a T4 TSH and checking whether the dose is okay.
Both
So
for
how do you calculate? How do you calculate the suppressive therapy dosage? Dosage of L-trox?
Ma'am, basically the dose.
All the faculty, madam, I think you can, Vijaya Patil, madam.
Yes,
Let it be a last question, then we'll conclude. Okay.
Basically, the TSH, the patient should not be clinically hyperthyroid, but the TSH should be,
Now, how do you
Just-
calculate dosimetry? What dose for what amount of residual disease, remnant disease? One line I already told, 30 millicuries for uptake in the thyroid bed. What more? I will put it across to you. Some people give 80 millicuries also if there is uptake in the neck. Okay. If there is uptake in the lungs, they give up to 200
If
millicuries.
there is metastasis or extra
Metastasis in
thyroid
the bones, they give 300 millicuries.
Yes,
See, there is a limit, more than 800 to 850. There is ceiling limit of radioactive iodine, beyond which side effects of radioactive iodine start. So you must know where to stop, how much to give.
Okay. I think I thank you very much, sir. Kindly pardon me because time is up now. I thank all the faculty, Dr. Our senior colleague, Dr. Rajgopal Shenoy, sir, for sparing your time. Dr. Shrishail Metgud, sir, Dr. Vijaya Patil, and thank you, sir, Adi, for joining us and helping us in this part, and our ex-ASI president, Dr. Siddesh, sir, and all the staff members, the senior surgeons and surgeons of Karnataka State, and our postgraduates. I also thank Dr. Chandrashekar, sir, for giving us an opportunity to be part of the ASI academic activities. We'll be part of the activities in future also. Thank you very much. Over to you, Dr. Chandrashekar.
Sir, just one sec, Dr. Patil, with your permission. Thank you. It was a great, with Rajgopal Shenoy, sir, it's always a great thing to have him around. There's so many things we also learned from sir. It was really great, sir. And I mean, I think overall she presented well, sir. I think we should compliment her.
Only thing she should drink some energy drinks, sir.
Sorry?
Confidence was a bit low.
Little voice.
Yes. That,
Wise.
Yeah,
That
voice
is
was a
great.
little bit low, sir, but otherwise she did well.
Yeah, she has done
Yeah.
well, sir. It's a good discussion. Overall,
Good
good
discussion.
discussion.
It was a fantastic discussion for more than 1 hour, 40 minutes.
Yes,
And,
sir.
I'm really sorry that we have to cut down or conclude in a hurry. Would have extended, but it's not getting late. I should
No, no.
thank the presenter for an excellent presentation, Dr. Yasaswini. So you have done a wonderful job. Many questions which were answered, and it's a learning process for everybody, teaching and learning process. And I should thank the faculty, Dr. Rajgopal Shenoy, as always, he is there, and Dr. Metgud sir and Dr. Vijaya-PATIL for an excellent session they have done today. And I should thank MB.PATIL for moderating so well. That overall it was a fantastic program to be there for 1 hour 40 minutes. And I should thank our immediate past national president, Dr. Siddesh sir, who chipped in and gave some tips also. And I thank all the members of KSCASI and the postgraduates who attended this program. And for your information, this program will be recorded, will be there in YouTube. Anytime you can go and watch in KSCASI YouTube. All our programs will be there in YouTube. So anybody, anytime you can watch. Thank you once again, everyone. Thank you one and all. Good night, everyone.
Only one
Thank you,
small
sir.
thing, Dr. Chandru, that
Yes, sir.
Yasaswini, congratulations. But for all postgraduates, you can make use of all these things, but remember, nothing like hands-on experience means please spend some time in the ward examine. You have your findings clarified with your faculty there, whatever palpation methods and all. They'll make use of all this e-learning. Okay, sir. Thank you, sir. Good night.
Thank you.
Thank
Thank
you,
you.
sir.
everyone.
Thank you.
Thank you, sir.
Thank you, Chandru.
Thank you,
Thank
sir.
you all.
Thank you.
Good night.
Thank you.
Thank
Yeah.
you.
Good night. Thank you, Patil,
night,
sir.
sir.
Thank you.
Thank you,
Thank you,
Patil.
Thank you, sir. Okay, sir. Thank you, sir. Thank you very much.
Thank you.
Good night, sir.
Good night. Good night. Good night.
ಚಲೋ ಈಗ ಎಷ್ಟು ಹೇಳಿದ್ದೀನಿ ಕಾನ್ಫಿಡೆಂಟ್ಲಿ ಮಾತಾಡು.
Thank you so much, sir.
Thank you. Thank you, Yasaswini. It was nice. Good